আসসালামু আলাইকুম। আমি ডাক্তার রুবিনা ওয়েলকাম করছি আপনাদের সবাইকে আজকে ক্লিনিক্যাল এক্সামিনেশন ক্লাসে। আসলে এটাকে ক্লাস বলা ভুল হবে, খুবই কষ্টকর এবং ডিফিকাল্ট একটা জিনিস। তো আমার মনে হয় পুরা ক্লাসটাতেই আমরা জাস্ট এটাকে নাই মামার চেয়ে কানা মামা ভালো, এরকম একটা সিচুয়েশানই আমার সকাল থেকে মনে হচ্ছিল যে কিভাবে দেখাবো, কি করব। আসলে প্রতিটা জিনিস তো সরাসরি দেখালে যেরকম হয় এখন হয়তো ঠিক সেরকম হবে না। সো আপনি এখন যেভাবে আমার অ্যাফোর্ডেবিলিটির মধ্যে যতটুকু ছিল আমি চেষ্টা করছি আমি আপনাদেরকে এক্সামিনেশনগুলো দেখানোর জন্য, এবং চেষ্টা করব অবস এবং গাইনিতে যে মেজর মিস্টেকগুলো হয় আমি এক্সামিনেশনের মাঝে মাঝে এক্সামিনেশনের প্রসিডিউরও বলবো, প্লাস ঠিক কোন কোন জায়গাটাতে আমরা বেশি ভুল করতাম সেই জায়গাগুলো বেশি মেনশন করব, যাতে সেই সেম রিপিটেশনও আপনার মধ্যে আর না হয়। তো আপনাদের সবাই কেমন আছেন আমাকে সবাই জানান। আশা করি সবাই ভালো আছেন। হ্যাঁ আপুরা, হ্যাঁ আলহামদুলিল্লাহ ভালো আছি। তো সবাইকে একসাথে হ্যাঁ সবার সালামের উত্তর একসাথে দিয়ে ফেললাম। গতকালকে আপনাদের রিসেন্ট আপডেটের ক্লাস ছিল, অনেকে হয়তো ক্লাসটা মিস করেছেন। যাই হোক, আজকে সেটারই কনসিকোয়েন্স যে ক্লিনিক্যাল এক্সামিনেশন অফস অ্যান্ড গাইনি একসাথে নিব। আপনাদের কারো যদি মাঝখানে কোনো ইনকোয়ারি থাকে অবশ্যই কোশ্চেন করবেন, আপনাদের যার যেখানে প্রবলেম কোশ্চেনগুলো করবেন। আমি ইন দ্য মিডল অফ দ্য ক্লাস অনেক কোশ্চেন হয়তো স্কেপ করে, আবার অনেক কোশ্চেন হয়তো আমি প্রসিডিউরের মাঝখানে থাকলে দেখতে পাবো না, বাট আমি আফটার দ্য এক্সামিনেশন দেখানো শেষ করে হলেও আমি আপনাদের কোশ্চেনের অ্যান্সারগুলো দেওয়ার চেষ্টা করব। সো অনেক ধৈর্য সহকারে আপনাদেরকে একটু বসতে হবে, কারণ ক্লিনিক্যাল এক্সামিনেশন আসলে অনলাইনে দেখানোর কোনো বিষয় নেই। অনলি জাস্ট ফর দ্য ফিলিংস of the difficulty during this COVID crisis period, that you could not go to the hospital, you could not attend the patient, you could not practice on the patient, you could not the clinical practice just on the feelings of that aspect. I am doing this effort. আচ্ছা, হ্যাঁ আপুরা, হ্যাঁ সবাই এই আপনাদের জন্য যে কষ্ট করছি এই কষ্টের জন্য আমার জন্য স্পেশাল দোয়া করে দিবেন আমার জন্য ইনশাল্লাহ। সো আসুন আমরা শুরু করি। আমাদের যেই টোটাল অবস এবং গাইনির যেই এক্সামিনেশনগুলো যেগুলো আপনার কেস রিলেটেড, সাপোজ অবস্টেট্রিক এক্সামিনেশন, থাইরয়েড এক্সামিনেশন, লিম্ফ নোড এক্সামিনেশন, দেন কার্ডিওভাস্কুলার এক্সামিনেশন, প্রিকর্ডিয়াম এক্সামিনেশন, দেন overall malignancy kichu case, and POCQ, VVF examination, cervical cancer examination, overall একটা abdominal lump, maybe fibroid, maybe ovarian lump, maybe benign, maybe malignant. In any case, you have to show your clinical expertization by the movement of your hands, by the movement of your fingers. That this is the opportunity. Within these times, very short time, you have to prove your confidence level and your expertization and skillness only within this short time during this clinical examination. So আসুন আমরা শুরু করি। কোশ্চেন থাকলে সবাই কোশ্চেন করেন, আমি যখনই হোক কোশ্চেনের অ্যান্সার দেব। So let's start. Now I will show the examination of the abdominal mass, specifically fibroid examination. If your case is fibroid, in case that and it is palpable and it is a big lump, in that case you should examine the lump like this way. At first, inspection. On inspection, abdomen is enlarged, the skin condition is normal, umbilicus is centrally placed, and there is a lump is visible just occupying the hypogastric region, nothing else. Now on palpation. On palpation, at first you have to show the palpation of the lump, then you will demonstrate the lump. At first, palpation of the lump, in case of the fibroid, there is no separate superficial palpation. Just palpate the lump with the two hands and try to feel its margin, mobility, try to feel its consistency, whether it is nodular or smooth surface. We remember that if it is single fibroid, the consistency will be, of course it is firm, but surface will be smooth if it is single fibroid. But if it is multiple fibroids, the surface will be irregular, nodular. So be careful in what situation, what comment you will give. Then after feeling of the lump as a whole, then you start to demonstrate the fibroid mass. A lump is palpable into the lower abdomen, occupying the hypogastric region. এটা আমি হাতে নিয়েছি এই কারণে there is no need to measure the fibroid mass with the measuring tip. You should describe the fibroid just by the size of the uterus, pregnant uterus size. So you just see the how much the size of the uterus. Suppose it is 16-week size fibroid. So you should describe is the lump is palpable into the lower abdomen, occupying the hypogastric region. It is almost 16-week size of the pregnant uterus. It is firm in consistency with smooth surface, regular margin, and mobile from the side to side, and but not above downwards, and the lower margin could not be felt. Now ekhane ekta question je how we can see the mobility. In that case amra jeta kori ebhabe mobility dekhi. No, this is the wrong technique. You have to fixed the one hand fixed, then push it and feel the mobility with the right hand. Then another, just like the reverse, the one hand is fixed, move it and feel with the opposite feel, just like this way, feeling of the mobility. This is all about the palpation. Then if you can do the percussion, the percussion note, you can comment the dull on the just over the mass is dull, and for that you can do a single percussion outside the mass and then a percussion over the mass. Then after percussion there is no need to see the auscultation, but as a routine you can see that vowel sound is present or not. Then you come to the parvaginal examination. This is in your bed case. You do this examination up to this level into your bed, but into the PV side you will do the parvaginal examination. Now I am showing the parvaginal examination of the fibroid mass. Fibroid, just as usual inspection, the vulva perineum apparently look healthy. There is especially here the important comment is there is no active bleeding. Active bleeding is not visible because your patient are presenting with the menorrhagia. So this comment is relevant here. There is no active PV bleeding is visible. Otherwise almost similar. Then you will do the pars speculum examination as usual, just introduction in the closed step, and there is no need to fixation of the screw. Just look at the cervix, inspection of the cervix. Cervix is healthy, then just discard it. There is no need to fixation. Fixation of the cervix is need in case of the PAPS, VIA, in that situation. Now I will do the bimanual examination. Bimanual examination is the art. এখানে হচ্ছে আপনার at first introduce the one finger, then two finger, then automatically my left hand will be over the suprapubic region, then start to describe the fibroid. Fibroid description hobe just like this. এখানে you should remember the don't repeat the same information, same message that you have already given by the para-abdominal examination. You should try to give some new message, some different message through the para-vaginal examination. So first of all, you say that the on bimanual examination the uterus is almost 16 week size of the pregnant uterus, firm in consistency, and it is mobile, non-tender, but it is continuous with the uterus. The mass cannot be separated from the uterus, and with the by this time apni ekhane with the movement of the mass, because ekhane ki korte hobe apnake, you have to say some points, you have to mention some points that can differentiate this mass, whether it is uterine origin or ovarian origin, whether it is fibroid or it may be differential diagnosis of ovarian tumor. So these 3 points must be mentioned here. Number 1 is already said. Second point is with the retraction of the mass part abdominally, the cervix moves, that indicate it is uterine origin. And number 3 point is third point is there is no cleft is felt between the lower pole of the mass and the uterus. And finally অবশ্যই আপনার হাত মুভ করবে, আপনার যখন আপনার abdominal hand মুভ করবে, that indicate you are palpating that side of the fornix and adnexa. There is no added pathology into the adnexa, and fornix is free. Then finally there is the controversy whether in case of the fibroid whether you will do a parectal examination or not, but maximum situation fibroid does not need the parectal examination. You should remember that there is some specific indication of some parectal examination, suppose case of the primary amenorrhea, intersex case, unmarried girl, any unmarried girl, parectal examination is very much helpful if this fibroid case is unmarried girl, unmarried PCO, unmarried fibroid, unmarried ovarian mass. In all this situation a parectal examination is the essential. And also Mullerian agenesis, and a parectal examination is essential for all the malignancy, all the especially the prolapse case and the VVF examination. Otherwise I don't think so that in case of the fibroid parectal examination is so much essential. So that's all about regarding the fibroid examination. Now I will show the cardiovascular examination. In your offset case, if you get the heart disease, especially mitral stenosis, in that case you must know the exact procedure of the precordium examination. Actually we don't need the detailed cardiovascular examination. Cardiovascular examination is something more else, like it include the examination of the details, pulse, symmetry, volume, regularity, there is radiofemoral delay, etc. But in your heart disease case you exclusively need the examination of the precordium. So don't worry for the details cardiovascular examination. So now I am going to show the precordium examination. Precordium examination just start korar age your approach should be like that. For precordium examination I have to expose the mother's chest from the including the both breast, but for examination purpose and just to maintain the privacy of the patient, I am going to show the precordium examination without exposure of the breast. এই কথাটা বলে নিলে examiner, especially foreigner, will be very happy and pleased, because you are proving that you know that for precordium examination, breast examination, at least up to the base of the breast should be exposed. So without exposure of the breast, I am doing this examination. So suppose this is precordium. Now I am showing the examination of the precordium. Just at first inspection. On inspection of the precordium, it is symmetrical in shape, no apex bit. একটু তাকিয়ে দেখবেন, মানে অন্যদিকে তাকিয়ে বললে just it's like a acting. There is no visible apex bit is seen, no visible cardiac scar mark, and there is no ectopic bit. Then palpation. For palpation, first point is palpation of the apex bit, but এটা হচ্ছে directly আপনি বলবেন কিভাবে? We know that the what is the location of the apex bit. It is 2.5 cm lateral to the mid clavicular line at the 4th intercostal space, but you are not so expert যে আপনি হাত দিয়েই সেটা পেয়ে যাচ্ছেন। সো এখানেও আপনার কিছুটা অ্যাক্টিং করে দেখাতে হবে। So suppose this is measuring tape. This is 1 to 2.5. So this is 2.5, and you see that this is mid clavicular line, and you count. You will search out the 4th intercostal space. Suppose this is 2nd intercostal space, 3rd and 4th mid clavicular line, and from here you go 2.5 cm from the mid clavicular line. So this is the point. Suppose this place. So now you at first you locate the apex bit. So eta jump kore you should not place your hand, because you are not so expert cardiologist যে আপনি জানেন যে ওখানেই আছে। সো এই অ্যাক্টিং গুলো আপনাকে করে দিতে হবে। এই যে 2.5, এই যে আমার মিড ক্লাভিকুলার, এখান থেকে যাচ্ছে 2.5 সেন্টিমিটার মিড ক্লাভিকুলার, কাউন্ট করে দেখালাম 4th। নাও আপনি ডেসক্রাইব করেন যে অ্যাপেক্স বিট, অ্যান্ড it is palpable not with the tip of the finger, not with this finger, just this palm eminence, with the help of this eminence. That is now the at first the location of the apex beat at left 4th intercostal space, 2.5 cm lateral to the mid clavicular line. At this time, simultaneous palpation of the left parasternal hip. Suppose this is a sternum, and left to the sternum, and just by this ulnar border, left parasternal hip is felt just lateral to the sternum. Then palpation of the palpable P2 at the 2nd intercostal space, palpable P2 and palpable A2. These points are very important for the pulmonary hypertension. If your case is somehow connected to the pulmonary hypertension, as we said in my clinical case of the heart disease, you see that if you are connected with the pulmonary hypertension, you must see the 3 things: left parasternal hip, palpable P2 and palpable A2. Then palpation of the other palpable murmur, that is thrill, palpation of the thrill, just like already apical area is felt, then tricuspid area, then apical area, then tricuspid area, then mitral area, then pulmonary and aortic area. Palpation of the thrill at the mitral area, tricuspid area, pulmonary area, then aortic area. Now the auscultation. For auscultation, as a whole, your auscultation should be like this at the same 4 area. auscultation of the heart sound at the at the mitral area, tricuspid area, pulmonary area, and aortic area. Suppose your case is the mitral stenosis. In that case, you have to do some extra physical activity, extra kashrot korte hobe. Seta ki? At first, you have to make the patient at left lateral position. Left lateral position, and you will turn over the stethoscope to the bell. Bell niye ashte hobe. Just bell niye ashte hobe. Then you describe the mitral stenosis. Mitral stenosis jono patient is in the left lateral position with the bell of the stethoscope in the mitral area, and patient ke bolte hobe breath holding, best here with the breath holding with inspiration. So ma apni ekta jore ekta lomba kore ekta shash nen, charen, stop, and this is the typical procedure to see the mitral stenosis, and there no need to see the radiation, because we know that in mitral stenosis there is no radiation. But if it is mitral regurgitation, in that case you have to again replace the patient in normal position, then again turn over to the diaphragm, then now ask the patient breath holding with expiration. So ma apni ekta lomba kore shash nen, lomba kore ekta shash nen, stop, breath holding with expiration. Now the mitral regurgitation, it has the radiation, so you have to see the radiation towards the axilla. In this auscultation, during this auscultation, you can place the thumb over the carotid pulsation, and just you are doing acting that whether there is whether this heart sound is murmur is corresponding with the carotid pulsation. If correspond, it is systolic. If not correspond, it is diastolic. This is all about the precordial examination, but this is not the end of the examination. After this point, you have to patient ke boshate hobe. You have to make the patient in sitting position. Then you must auscult the bilateral lung base for the basal crepitation. Basal crepitation can be ausculted into the chi area at the mid axillary, mid clavicular, and at the whatever. And in that case, if your case is pure mitral stenosis, after doing this examination like this, you have to describe the mitral stenosis. We know that the typically it is a rough and rumbling, tapping in nature, mid-diastolic murmur, best heard in the left lateral position, with the bell of the stethoscope, in the breath holding with the breath holding with inspiration, and there is no radiation. This is the typical characteristics of the mitral stenosis. So your precordial examination will be completed after the auscultation of the lung base. So thank you so much. This is all about the precordial examination. Assalamu alaikum. Now I will show the general examination. Before general examination, you have to consider some preparation. That at first you have to place at the right side of the patient. You will ensure the proper light so that you can see the anemia and jaundice. Especially one thing you should remember, that overall detailed general examination in obs or gynec is rare. Maximum time you will face the relevant question like show me anemia. Suppose your case is thalassemia, so show me anemia. Suppose your case of obstetric cholestasis, so examination show me the jaundice. Suppose your case is the preeclampsia, so show me the jar. sharp. Suppose your case is purpura, so show me the examination of the limb to see the any evidence of the DVT. Just relevant question you asked from the general examination, but you have to practice the chronological sequence of the general examination. So you must practice it before examination. Without practice, if it do it directly in the examination hall, you will skip the different steps of the general examination. That will be very detrimental for you, because this is the history. This is the history in the past that so many examinee showed the anemia when examiners say to see the jaundice, and we show the jaundice when examiner want to see the anemia. So this is the very gross mistake. You know the thalassemia pathogenesis, you know the iron metabolism, you know the management, treatment, everything, but if you don't capable to show the anemia and jaundice, you will never pass in the clinical examination of the obs or gynae. So now I will start. The general examination should be start from the over the head. Over the head, just simple. Just one thing is that this is not the neonatal examination. This is my mother. This is my mother, patient, and consider it as a lady. This is not the neonate, because আজকে তো সব মানে দুধের স্বর যে ঘোলে মেটানো সেটাই হবে, আমরা যেহেতু প্র্যাকটিক্যালি পেশেন্ট পাচ্ছি না, so all the examination will be on the dummy, so consider it as a lady. আচ্ছা, যাই হোক, তো examination, general examination will be started from the head. Just take simple palpation to see the any gross skull deformity, then then show the anemia at the lower palpebral conjunctiva. Then automatically this thumb and index finger will be over the upper sclera, retracting, and see the jaundice. Then tip of the nose, then palpation of the ear lobule, then come to the mouth. In the mouth we have to see different thing, like একটু মুখটা খুলেন, then you can see the at first tongue, dorsum of the tongue, that is anemia, undersurface of the tongue, that is jaundice, distribution of the papilla, whether it is whether any flattening of the papilla, whether any firing of the tongue, whether any geographical tongue or any evidence of the fungal infection, or then come to the corner of the mouth, that is any evidence of the angular stomach, that is all these are the sign of the macronutrient deficiency. Then after completion of the oral cavity, then you come to the neck. Grossly you ask the patient just to deglute it and see whether any visible swelling. Then come to the breast. Overall, during the general examination, you don't need the detailed breast examination, but over the clothing, you can do the just a simple superficial breast examination. Now come to the hand. Just after coming to the hand, at first you see the pulse, and pulse examination is the art. So don't do any mistake during examination of the pulse, just like the handshake manner and these 3 fingers over the pulse, arterial pulsation. Then after pulse examination, now you see the at first you see place this thermometer under the axilla. By this time, I mean it এখানে পড়ে যাবে তাই just axilla তে থাকবে. By this time you place the BP cuff, and after BP cuff then it remove and see the temperature. Just remember one thing, in case of the prom and purpurium, to see the peripheral pyrexia or any evidence of the chorioamnionitis. In these two cases, peripherum and palm, this thermometer placement is essential, and temperature recording is very, very important. And you have to face this, whether you examine the temperature. Okay, by this time BP, pulse and temperature is seen, and now downwards. That's just moving to downwards. Simply just palpate the superficial inguinal loop. Just palpate like this, superficial inguinal loop. This is এভাবেও করতে পারি, just এভাবে করতে পারি, but এভাবে করলে একটু opposite টাইপের হয়, so এভাবে করতে পারি. I am standing on the right side of the patient, then come to the leg. Just peripheral case হলে এখানে আপনার whether there is any symmetry or asymmetry, or whether any calf swelling, tender swelling is visible or not. That is important. And finally you watch the sole of the foot and overall skin. This is all about the general examination. In gynecological malignancy case, during the general examination you must show the lymph node examination, especially the supraclavicular axillary lymph node examination, because we know that there is varicose gland enlargement hote pare. So this is all about the general examination. Now I will show the clinical examination of the myomatous polyp. In the clinical case, sometimes you have to face this type of the case. So I will start now. At first, I will not show any preliminary steps, any position of the patient, and as usual valval wash. Just ignoring all that, I will showing the original steps. At first inspection, suppose this is the myomatous polyp that is visible outside the introitus. So your description will be like that: a single pinkish polypoidal mass is hanging outside the introitus, the leading part of which shows no external loss of the cervix. There is no evidence of the foul smelling discharge, and within the polyp there is no evidence of the hemorrhage or necrosis that indicate the no evidence of the infection. Now I will do the speculum examination. You have to assess if the size of the myomatous polyp is smaller, then you can introduce this type of the cuscus speculum. But if it is so broad and so big mass myomatous polyps, in that case you will face the very difficulty to introduce the cuscus speculum. So there is a scope to introduce this type of the speculum only if the polyp is small in size. And one thing I want to let me clear one thing. You have to practice to hold this type of the cuscus speculum, not like this, not like this. All these are the wrong maneuver, and if you hold this cuscus speculum in a wrong technique, your impression will be very bad and your examiner will not give you the standard mark in your clinical examination. So the correct approach to hold the cuscus speculum is like this, under the guidance of the index finger, like this, and your thumb will be over there, so that you can close and open it. So for speculum examination, I will introduce it just like this manner. And of course, after apperting the labia majora with the thumb and index finger of my left hand, but you should not demonstrate this. Just you will show it After apperting the labia majora, then introduction of the cuscus speculum. And fixed it. Now you describe the pars speculum examination like that cervix is petulous. Then whatever you say, you can see only the tip of the polyp, you can see the whole polyp, or you can see nothing, just a polypoidal mass is coming to the internal os of the cervix. Whatever you see, that should be described by you. Suppose a tip of the, you can describe it, the tip of the polyp is visible. It is, if it is fresh, then you can say it is healthy and smooth surfaced polyp. If it is infected, you can describe it, the tip of the polyp is felt and it is this is pars speculum examination, so you can say this is pale, infected, ulcerated, and attached with the pedicle, or having the connection or attachment with the narrow stalk. Whatever you say, if it is healthy or unhealthy, necrosed, inflamed, evidence of the sloughing, evidence of the ischemia, necrosis, whatever you say. If these are not present, you should not mention this or mention this. Just say the tip of the polyp if well smooth surfaced polyp. That is enough. Next, withdrawal of the speculum. Just like this hole and opening, these steps should not be mentioned. Just withdrawal speculum and final withdrawal, of course, with the closed state. You never withdrawal of the speculum in this open manner. There will be chance of the injury and that is very painful. So you must withdraw this speculum in a closed status. Closed steps. That's why the holding manner of the cuscus speculum is like that, with the support, with the guidance of this index finger. Now, bimanual examination. For bimanual examination, sometimes someone is confused. At first the routine bimanual examination e chola jay, but it is a wrong technique, as this is the case of the myomatous polyp. So at first you have to examine the polyp. So your bimanual examination first approach will be like that. The tip of the polyp or part of the polyp or as a whole polyp is felt by my hand, and it is pale, infected, ulcerated, necrosed, or a smooth, healthy surface, whatever. And it is firm in consistency, not tender, mobile from side to side, and attached with the narrow stalk. And also it either bleeds or not bleeds to touch, usually not bleeds to touch. And finally the assessment of the size of the uterus. It is firm in consistency at 8-week size, bulky, or 8-week size, mobile from the side to side, non-tender, etc. And finally give a comment on the fornix and adnexa. Fornix is clear, there is no added pathology in the adnexa. This is all about the myomatous polyp examination. Finally, you will say your diagnosis. This is the case of the not myomatous polyp. You can say according to the palm point classification as the AUPP. That's all about the myomatous polyp examination. Assalamu alaikum. Now I will show the thyroid examination. In case of the obstetric case, thyroid case, pregnancy with the hypothyroidism or pregnancy with the thyrotoxicosis. In that case, you have to show the examination of the thyroid gland. Otherwise, in case as a whole, in routine general examination, in maximum time thyroid gland is not enlarged, so it does not need the detailed thyroid examination to show, just only inspection to whether thyroid gland is enlarged or not. So now I will show you the thyroid examination on this lady. Just you have to remember at first, the thyroid examination should be started from the pulse examination. So if your case is thyroid problem, and you have to start the thyroid examination from the palpation of the pulse, then feeling of the palm of the hand. At first I will show the pulse, and the pulse examination is also a art. During thyroid examination, if you do a gross mistake to examine the pulse, that will be a grave mistake. There will be no mercy. So it's suppose undergraduate, this is undergraduate study how to see the pulse. Just hold like this handshake manner, and just with this 3 finger feel the pulsation. Now pulse, whether tachycardia or bradycardia, and see just 1 minute. Then palpation of the palm, whether it is dry or wet, because hypothyroidism will be there. Hypothyroidism or hyperthyroidism, this status of the palm will give the details information. Just say it is rough or smooth and wet, whatever you say. Then thyroid examination, original examination is started. Thyroid examination at first, it will be started from in front. So আচ্ছা আমি তোমার কি হচ্ছে এটা তো গলা পড়ে আছো। আচ্ছা, thyroid examination should be started from in front. Patient will be here and I will be placed in front of the patient. Now আপনি একটা ঢোক দিলেন, there is a swelling in the neck which is moves with the deglutination. Just only this information. Then you will stand just behind the examination. Thyroid examination should be started from in front. Just inspection is from in front. Just the thyroid swelling is visible and it moves with the deglutition. Then after standing behind the patient, now I will palpate the thyroid gland. For that, again I will ask the patient to deglute. Apni abar dhokile. Okay. You have this patient have the original mild thyroid gland enlargement. Whenever you palpate, you just fixed your tip of the finger of both hand just at the lower margin of the thyroid swelling, and it should I will place my tip of the fingers. Dogilen, when she degluted, just cut the lower margin, and you should describe it like this, that a thyroid swelling is felt in my hand, which is either soft to firm in consistency, or in case of thyroid malignancy, it is hard in consistency and mobile and not fixed with the underlying structure, smooth or nodular in surface. Then I will just for palpation of the right lobe, just some deviation to the left side. Palpation of the right lobe, then again palpation of the left lobe. Thus the thyroid examination still not is completed. Finally, I have to auscultate the bruit, thyroid bruit, just like that. One thing is, remember, আচ্ছা, third examination is completed. Thank you. You can go. আপনি এখন যান, আপনাকে আবার ডাকবো। আচ্ছা, এটা পেশেন্ট। এখন হচ্ছে আমরা হচ্ছে থাইরয়েড এক্সামিনেশনে আপনার শুধু মনে রাখবেন অত খুব একটা আমাদের অপসের কেস গাইনিং কেসে খুব একটা লাগে না, এক্সেপ্ট দ্য কেস যখন আপনার থাকবে। দ্যাটস অল অ্যাবাউট দ্য থাইরয়েড এক্সামিনেশন। Now I will show you the lymph node examination. Just remember one thing, that during general examination you don't need so elaborate lymph node examination except the gynecological malignancy. Suppose cervical cancer, ovarian, or endometrial carcinoma. In ovarian cancer there is a question of the varicose gland enlargement. So in that situation you have to you have to examine the lymph node details. So I am showing, just going to show the lymph node examination. If the examiner asks to show, are you to shamne agao? Acha. If you show the if examiner want to see the details lymph node examination, you must to do that. So better to just practice only for at least for one time the thorough lymph node examination. Remember one thing, that lymph node examination should be started by standing behind the patient. Lymph node examination should be started from behind. That means I will stand behind the patient. At first take the consent যে আমি আপনাকে একটু পরীক্ষা করব, ঠিক আছে? আচ্ছা, এটা একটু নামাচ্ছি। ওকে, the lymph node examination, at first I will palpate the chronological order. At first palpation of the submental, it is nothing serious. At first submental, then submandibular, then automatic. The hand will be over the preauricular, then anterior cervical chain. Then এটা একটু উপরে তোলেন, বসে থাকেন, শুধু এইটা উপরে তোলেন, উপরে এই যে এরকম করেন, হ্যাঁ। দেন সুপ্রা ক্লাভিকুলার, দেন পিছনে চলে আসেন, posterior cervical, posterior auricular, then occipital. This is all about the lymph node examination. একটু ঘুরে বসেন এইদিকে। আচ্ছা, now I will do the axillary lymph node examination, and in case of the breast examination, sometimes in case of the CBE, complete clinical breast examination, কিন্তু one of the part যে axillary lymph node palpation করা, সেখানে sometimes we are confused regarding the placement of the hand. The one tips is that during the axillary lymph node examination you must wear the gloves. Then it is left side, right side. Just practice like this, that just like this, and examination with the right hand. I am examining the left-sided patient's right-sided axillary lymph node examination. So my hand is over the patient's shoulder. Patient hand is rest on my. If I am in the sitting position, then she can rest her hands over my shoulder. If I standing position, even she can keep this like this way. Then examination by the opposite hand. By opposite hand you can palpate the anterior group, lateral group, apical group, and posterior group. And just in the similar manner in the opposite side, patient's hand will be my right shoulder. If I sit like this position or standing position hole একটু discomfort হয়, and patient's right hand is supported by my right hand, and the examination should be done by the left hand. But I am doing the axillary lymph node examination of the left side, but examination is also done by my left hand. Central, apical, anterior group, posterior group. This is all about the examination of the axillary lymph node. আচ্ছা, তোমার নাম কি? কুলসুম। থ্যাংক ইউ। যাও। আচ্ছা, this is all about the examination of the lymph node. Assalamu alaikum. Now I will show the vaginal examination part of the VVF examination. Before examination, I have to mention just one thing, that in case of the fresh VVF examination, we have to do the paraspeculum examination at first, but in case of the old fistula, or when the fistula is associated with the stenosis or excessive amount of the scar tissue, or repeated failure, where the situation is very painful, you should remember in that situation we have to do at first the bimanual examination by introducing one finger. If patient feels no pain, then I will introduce two finger. If patients no feeling of the pain, then I can introduce this type of the Sims speculum. But in that case, old case, repaired case, failed case, associated with stenosis, where excessive amount of the scar tissue, if we introduce this speculum at first, the patient will feel so much pain that the examiner will be irritated. So that is one thing. But in case of the fresh fistula, usually we can do the paraspeculum examination at first, then the bimanual examination. So now I will start the vaginal examination. As usual, after taking the consent, patient preparation, position, then covering, patient should be at the edge of the table. This is the preliminary steps, and this should not be described by oral commentary. This is the steps that should be shown by the manual procedure. I will show the procedure. So after wearing the gloves, at first the first steps is just inspection. Before inspection, antiseptic washing of the vulva. Some examiner does not like it during the examination, but if the cotton swab and wash kit is present in your examination table or trolley, you can give the perineal wash, and this should not be described, just show. And it should be discarded. For examination purpose, I am showing this with the one swab, but it should be by the 3 different cotton ball. Now you should describe the inspection finding. On inspection, the vulva perineum is apparently healthy, and urine is coming through the introitus. Uriniferous smell is coming from the vulva and her clothing, but there is no excoriation of the vulva, no evidence of the fecal contamination, no evidence of the perineal tear or complete perineal tear. Then I will do the paraspeculum examination, but this is the art. Before introduction of this type of the speculum, we must apart the vulva with the thumb and index finger of my left hand, just like this, and just like this, and then introduction of the same speculum. During this examination of the VVF, you should never never should examine by standing position. You must sit just like this position for the proper visualization of the fistula. Orthat, you must maintain the position of the introitus, at the level of the introitus, just like this. And by this position you should describe the fistula's opening. That suppose a fistula's opening is visible at the fistula's opening. A fistula's opening is visible at the middle part of the anterior vaginal wall, through which urine is continuously coming out and cervix is healthy. But one thing is important, that if it is post hysterectomy vault fistula, in that case you must mention that cervix is absent, uterus is absent. Sorry, parspeculum examination only cervix comment is enough. Then you can do the bimanual examination, and at first introduction of the index finger, then 2 finger, and automatically left finger will be at the suprapubic region, but it should not be mentioned. Bimanual examination, this is the art. By keeping the hand within the introitus, just you are describing the total positive and negative findings, like that and it must be correspond to your parspeculum examination. It should be like that. There is a fistula's opening is visible. Fistula's opening is visible at the middle of the anterior vaginal wall, that admit the tip of the finger seems to be 1.5 into 1.5 centimeter in diameter, with a well-defined margin, and the minimum amount of the scar tissue having no attachment with the underlying bony structure, and it is away from the external rectal meatus and away from the cervix. And cervix is healthy, uterus is soft, anteverted, non-tender, and adnexa is normal. But in case of the post-hysterectomy vault fistula, you must mention cervix is absent, uterus is absent. Now I will do the digital rectal examination. Before that, you must lubricate the index finger with the lubricant. Then just by doing this, you can mention that on digital rectal examination, the rectal mucosa is free. There is no evidence of the rectovaginal fistula and complete perineal tear. And finally, you give a comment on the grip of the anal sphincter grip. So for that, just keeping the index finger at the anus, and patient is asked to hold it and give a comment that the sphincter grip is intact. And the final steps is this instrument should be discarded in the proper position in a bowl or bucket containing the 0.5% chlorine solution. This is not the ending. You must clean the vulva and reposition, and you must cover the introitus, and finally you must give a thanks to the patient for her cooperation. So this is all about the VVF examination. Now I will show the examination of ovarian lump, especially the ovarian malignancy. At first inspection, on inspection, abdomen is enlarged, or if ascites, you can say hugely enlarged. Umbilicus is centrally placed and everted. There is no visible peristalsis and no visible incision mark, and a lump is visible into the lower part of the abdomen, occupying the hypogastrium and the part of the iliac fossa. Suppose this is an lump, ovarian lump. So now I am showing how to present the case of the malignant ovarian tumor. After inspection, then palpation. The palpation should be started with the superficial palpation. Superficial palpation should be just like this. Superficial palpation to assess just whether there is any tenderness, and finally you can feel the overall temperature of the skin condition with the dorsum of the hand. Then start the deep palpation. On deep palpation you can feel a lump. Then you will start to demonstrate the positive features of the lump. Suppose a lump is palpable in the hypogastrium, including the part of the right and left iliac fossa. It is almost suppose when you will demonstrate the lump, by the same time simultaneously you will do the examination, or at first you have completed the examination, then you can describe the feature as you wish, according to your benefit. Suppose this is the lump, so in this case you must to measure it. We remember in case of the fibroid you need not to measure the lump. So this is, suppose it is 10 centimeter and this is 12 centimeter. So you can say the diameter of the palpable part of the mass is 10 into 12 centimeter, and it is irregular surface, ill-defined margin with the restricted mobility in all direction, and non-tender or tender, whatever it is, and the lower margin could not be felt. And finally, after lump examination, you have to palpate the liver and spleen and kidney. Suppose I am standing on the right side, so for liver palpation I have to examine the just right hypochondria, right side থেকে শুরু হবে, and liver palpation, spleen palpation, and ballotment test of the kidney. If in any case of the malignant ovarian tumor, you have to include this part, but in case of the benign ovarian tumor এটা হচ্ছে not essential, but malignancy ক্ষেত্রে the palpation of the liver is essential. And liver palpation technique is just at the intercostal space, just placing this aspect of the index finger, then just proceed towards the opposite side, just proceed towards the palpation, whether it is palpate, then goes opposite side to palpate the spleen. And you know the how to ballotment test of the kidney is done. Then this is the part of the palpation, and this should not be skipped during the palpation, without palpation of the liver. Then I will go for the percussion node. Percussion node, the important thing is, at first you do a single percuss outside the lump, then over the lump. Then you can see that the mass is dull, centrally dull, and then you can say the another strike should be given in both iliac fossa. Then you can say the both flank is flank, there is resonance in both flank. This is the percussion note. And now I will see the shifting dullness. Shifting dullness will be positive in case of the moderate ascites. So shifting dullness, you know, your percussion note will be started from here, and you will do like this, and upor theke ashbe. Suppose this is umbilicus, so your percussion note will be like this. Then when you will find, then patient will be reverse in opposite direction and wait for some while. Then again Parcus, this is if it is dull, so again go to the umbilicus, and when come to the opposite side, again patient is reverse and wait for some minute. Then again Parcus, if it is dull, then forward to again to the umbilicus. So এটা আমাদের ছোটবেলার পড়া, this one, this and this is shifting dullness. যদি আপনি শিফটিং ডাউননেস পজিটিভ বলেন সেক্ষেত্রে দেয়ার উইল বি নো ইউজ অ্যাসাইটিস, যে আপনার ফ্লুইড ছিল পজিটিভ হবে। সো ফ্লুইড ছিল দেখার নিয়ম হচ্ছে পেশেন্টস হ্যান্ড উইল বি প্লেসড ওভার দ্য অ্যাবডোমেন জাস্ট লাইক দিস, অ্যান্ড জাস্ট বাই প্লেসিং দ্য হ্যান্ড, your hand in the opposite side, you will stroke the abdominal wall just like this. And if the fluid chill is you feel, that is fluid chill positive. Be remembered that simultaneous shifting dullness and fluid chill is usually not positive simultaneously. If either shifting dullness positive, fluid chill negative, or fluid chill positive, shifting dullness will be negative. And this is the abdominal lump examination, and you can also do the auscultation. During the pervaginal examination for the malignant ovarian tumor, nothing special. You will do inspection, per speculum examination, then bimanual examination. I'm saying just the bimanual examination, how you will present the bimanual examination of the malignant ovarian tumor. You will say that at first you should give the comment that uterus is normal in size, and a mass is felt to the right fornix, late fornix, or anterolateral fornix, whatever it is, and it is partly solid, partly cystic in consistency, irregular, ill-defined, tender. And now again you should establish the points to differentiate it from the uterine origin. So you must say the comment that the mass is fixed, restricted, with the restricted movement in all direction, and with the movement of the mass per abdominally, the cervix fails to move, and there is a cleft felt in between the lower pole of the mass and uterus. But be careful, if it is very advanced stage of the malignant ovarian tumor, you should not describe the so beautiful things. You just say that the mass is cannot be separated from the uterus. The এত বেশি ascites, এত বেশি advanced stage, আপনি simply বলবেন যে the exact side size or exact position, exact site consistency, exact size cannot be delineated due to restricted movement of the mass, because the mass the uterus mass cannot be separated. আপনি বলবেন যে the mass cannot be separated from the uterus, and exact size and consistency cannot be delineated because of the huge adhesion. And finally you have to do the digital rectal examination. In this case the digital rectal examination is essential, and just you will say that the rectal mucosa is free and hard, fixed and tender. Nodule is felt in the pouch of the Douglas. Felt or not felt? If felt, you will say. If not felt, you will say not felt. And first comment should be a mass is felt to the rectal wall. The digital rectal examination comment gula kirokom hobe. The first comment is the mass is felt to the rectal wall, rectal mucosa is free, and third comment, hard, fixed, tender nodule is felt in the pouch of the Douglas. Then you can say the diagnosis, it's a ovarian tumor, probably malignant ovarian tumor. So this is all about the examination of the malignant ovarian tumor. Assalamu alaikum. I'm Dr. Rubina. Today I will show the POPQ procedure. In fact, we do a combined and a mixed POPQ and traditional some steps of the prolapse examination. But the question is, in your examination, what procedure you will follow. If you see that the graduated speculum like this, our speculum is supplied, pen and the grid paper is supplied in your exam table, you should do the POPQ staging. But if these are not supplied in your examination table, you have to take the decision to show the traditional approach. Today I will show the original POPQ staging. You should remember that in case of the POPQ staging, there is no need to do the get above the swelling test, no need to do the extra method of the traditional procedure. So now I will start just how to present the original POPQ system examination during examination. So at first there is some preparation, that is you have to I will place the patient at the edge of the table. I will ensure the proper light exposure from the behind, and of course patient is on the examination table under the maturation, and the vulvar perineum is covering, and there is the question of the washing. In case of the POPQ examination, I will give only 2 wash on right side and discard over the bucket containing 0.5% chlorine solution, and the another wash on this side, contralateral side. But no wash should be given over the prolapsed mass, because this will hamper to place the POPQ point. Only 2 side wash, then discard it on the bucket containing the chlorine solution. Antiseptic wash is done. Now I will wear the gloves, and for your visual impression, I am originally wearing these gloves. After wearing the gloves, this hand should be just like this approach, and then you will describe and demonstrate all the points of the inspection. This is very important, and examiner will note it, what points you will leave. So you say that you should not start your demonstration from the prolapsed mass, because someone preferred that you should describe the overall genitalia, what is normal, what is abnormal. So on inspection, the vulvar perineum apparently looked healthy but seems to be atrophied, and there is loss of the vaginal rugosity. There is no evidence of the vulval epithelial skin disorder or vulval dystrophy. No foul smelling discharge coming through the introitus. And now you say there is the mass protruding through the introitus, the leading part of which shows the external os of the cervix. By this time you ask the patient to cough. Then describe there is another bulging just above the protruding mass on the anterior vaginal wall. As coughing was passing through it with the diffuse margin, it's suggestive of the cystocele. But in POPQ system there is no such type of the terminology of the cystocele, but you can say it. Then you describe that if it is present, you say that there is the visible decubitus ulcer. There is tiny decubitus ulcer is present over the anterior lip of the cervix. Seems to be 1.5 into 2 cm in diameter with well-defined margin, and there is presence of some slough. Then there is some visible keratinization, but no pigmentation is present. That's all about the inspection. Now I will do the reposition of the mass. At this time I will do the reposition of the mass, and when I will do the reposition of the mass, at this moment I will do the routine bimanual examination. Bimanual examination actually is not the part of the POPQ staging, but you can do it. You must do it as a routine gynecological examination. So you describe and demonstrate is like that. On bimanual examination, uterus is normal, anteverted, soft, non-tender. Adnexa is free, no added adnexal pathology is there, and fornix is free. Now, ma'am, now I will start the original POPQ staging. As for POPQ staging, I need a complete empty bladder, so there is no scope to see the stress incontinence. এখানে স্ট্রেস ইনকন্টিনেন্স দেখে unnecessary examination এবং পরীক্ষাকে ক্লামজি করার কোনো প্রয়োজন নাই, because here the bladder is not full, here the bladder is empty, so there is no scope to see the stress incontinence. Now I will start the steps of the POPQ staging. For that, at first I will take two measurement, that is genital hiatus and perineal body. Genital hiatus is from the foresheet to external urethral meatus, that is 4 cm, 4 or 5 cm. Perineal body is from the foresheet to midpoint of the anus, that is 3 cm. Now I will show the cardiovascular examination. In your OPSE case, if you get the heart disease, especially mitral stenosis, in that case you must know the exact procedure of the precordium examination. Actually, we don't need the detailed cardiovascular examination. Cardiovascular examination is something more else. Like it include the examination of the details, pulse, symmetry, volume, regularity, there is radiofemoral delay, etc. etc. But in your heart disease case, you exclusively need the examination of the precordium. So don't worry for the details cardiovascular examination. So now I am going to show the precordium examination. Precordium examination, just to start korar age, your approach should be like that. For precordium examination, I have to expose the mother's chest from the including the both breast, but for examination purpose and just to maintain the privacy of the patient, I am going to show the precordium examination without exposure of the breast. এই কথাটা বলে নিলে examiner, especially foreigner, will be very happy and pleased, because you are proving that you know that for precordium examination, breast examination, at least up to the base of the breast should be exposed. So without exposure of the breast, I am doing this examination. So suppose this is precordium. Now I am showing the examination of the precordium. Just at first inspection. On inspection of the precordium, it is symmetrical in shape, no apex bit. একটু তাকিয়ে দেখবেন, মানে অন্যদিকে তাকিয়ে বললে just it's like a acting. There is no visible apex beat is seen, no visible cardiac scar mark, and there is no ectopic beat. Then palpation. For palpation, first point is palpation of the apex beat, but এটা হচ্ছে directly আপনি বলবেন কিভাবে? We know that what is the location of the apex beat. It is 2.5 cm lateral to the mid clavicular line at the 4th intercostal space, but you are not so expert যে আপনি হাত দিয়ে সেটা পেয়ে যাচ্ছেন, so এখানেও আপনার কিছুটা অ্যাক্টিং করে দেখাতে হবে. So suppose this is measuring tape. This is 1 to 2.5. So this is 2.5, and you see that this is mid clavicular line, and you count. You will search out the 4th intercostal space. Suppose this is 2nd intercostal space, 3rd and 4th. third and fourth mid-clavicular line, and from here you go 2.5 centimeter from the mid-clavicular line. So this is the point. Suppose this place. So now you at first you locate the apex bead. So eta jump kore, you should not place your hand because you are not so expert cardiologist যে আপনি জানেন যে ওখানেই আছে। সো এই অ্যাক্টিং গুলো আপনাকে করে দিতে হবে। এই যে 2.5, এই যে আমার মিড ক্লাভিকুলার, এখান থেকে যাচ্ছে 2.5 সেন্টিমিটার মিড ক্লাভিকুলার, কাউন্ট করে দেখালাম 4th। নাও আপনি ডেসক্রাইব করেন যে অ্যাপেক্স বিট অ্যান্ড ইট ইজ palpable not with the tip of the finger, not with this finger, just this palmar eminence, with the help of this eminence. That is now the at first the location of the apex bead at left 4th intercostal space, 2.5 centimeter lateral to the mid clavicular line. At this time, simultaneous palpation of the left parasternal hip. Suppose this is a sternum, and left to the sternum, and just by this ulnar border, left parasternal hip is felt just lateral to the sternum. Then palpation of the palpable P2 at the second intercostal space, palpable P2 and palpable A2. These points are very important for the pulmonary hypertension. If your case is somehow connected to the pulmonary hypertension, as we said in my clinical case of the heart disease, you see that if you are connected with the pulmonary hypertension, you must see the three things: left parasternal hip, palpable P2 and palpable A2. Then palpation of the other palpable murmur, that is thrill, palpation of the thrill. Palpation of the thrill, just like already apical area is felt, then tricuspid area, then apical area, then tricuspid area, then mitral area, then pulmonary and aortic area. Palpation of the thrill at the mitral area, tricuspid area, pulmonary area, then aortic area. Now the auscultation. For auscultation, as a whole, your auscultation should be like this at the same 4 area. Auscultation of the heart sound at the at the mitral area, tricuspid area, pulmonary area, and aortic area. Suppose your case is the mitral stenosis. In that case, you have to do some extra physical activity, extra koshrot korte. Now I will show the examination of the abdominal mass, specifically fibroid examination. If your case is fibroid, in case that and it is palpable and it is a big lump, in that case you should examine the lump like this way. At first, inspection. On inspection, abdomen is enlarged. The skin condition is normal, umbilicus is centrally placed, and there is a lump is visible just occupying the hypogastric region, nothing else. Now on palpation. On palpation, at first you have to show the palpation of the lump, then you will demonstrate the lump. At first, palpation of the lump, in case of the fibroid, there is no separate superficial palpation. Just palpate the lump with the 2 hands and try to feel its margin, mobility, try to feel its consistency, whether it is nodular or smooth surface. We remember that if it is single fibroid, the consistency will be of course it is firm, but surface will be smooth if it is single fiber, but if it is multiple fibers, the surface will be irregular, nodular. So be careful in what situation, what comment you will give. Then after feeling of the lump as a whole, then you start to demonstrate the fibroid mass. A lump is palpable into the lower abdomen, occupying the hypogastric region. Eta ami hate niyechi, ei karone there is no need to measure the fibroid mass with the measuring tip. You should describe the fibroid just by the size of the uterus, pregnant uterus size. So you just see the how much the size of the uterus. Suppose it is 16-week size fibroid. So you should describe is the lump is palpable into the lower abdomen, occupying the hypogastric region. It is almost 16-week size of the pregnant uterus. It is firm in consistency with smooth surface, regular margin, and mobile from the side to side, and mobile from the side to side, but not above downwards, and the lower margin could not be felt. Now ekhane ekta question je how we can see the mobility. In that case amra jeta kori ebhabe mobility dekhi. No, this is the wrong technique. You have to fixed the one hand fixed, then push it and feel the mobility with the right hand. Then another, just like the reverse, the one hand is fixed, move it and feel with the opposite feel, just like this way, feeling of the mobility. This is all about the palpation. Then if you can do the percussion, in the percussion note you can comment the dull on the just over the mass is dull, and for that you can do a single percussion outside the mass and then a percussion over the mass. Then after percussion there is no need to see the auscultation, but as a routine you can see that vowel sound is present or not. Then you come to the parvaginal examination. This is in your bed case. You do this examination up to this level into your bed, but into the PV side you will do the parvaginal examination. Now I am showing the parvaginal examination of the fibroid mass. Fibroid, just as usual inspection, the vulva perineum apparently look healthy. There is especially here the important comment is there is no active bleeding. Active bleeding is not visible because your patient are presenting with the menorrhagia. So this comment is relevant here. There is no active PV bleeding is visible. Otherwise almost similar. Then you will do the pars speculum examination as usual, just introduction in the closed state, and there is no need to fixation of the screw. Just look at the cervix, inspection of the cervix. Cervix is healthy, then just discard it. There is no need to fixation. Fixation of the cervix is need in case of the PAPS, VIA, in that situation. Now I will do the bimanual examination. Bimanual examination is the art. At first introduce the one finger, then two finger, then automatically my left hand will be over the suprapubic region. Then start to describe the fibroid. Fibroid description hobe just like this. You should remember the don't repeat the same information, same message that you have already given by the para-abdominal examination. You should try to give some new message, some different message through the parvaginal examination. So first of all you say that on bimanual examination the uterus is almost 16 week size of the pregnant uterus, firm in consistency, and it is mobile, non-tender, but it is continuous with the uterus. The mass cannot be separated from the uterus, and with the by this time apni ekhane with the movement of the mass, because ekhane ki korte hobe apnake, you have to say some points, you have to mention some points that can differentiate. Assalamu alaikum. Now I will show the obstetric examination, and this is compulsory in all of your obs case. Obstetric examination should be started with the inspection. Here the most important thing is that during examination you have to concentrate what question you have been asked. If it is show me the obstetric examination, in that case your examination will be start from the inspection. If say the show me the obstetric grip, in that case your examination will be start from the fundal grip. If you are asked to show the only symphysiofundal height, then your examination is only see the symphysiofundal height. If your question is examine the abdomen in your obs case, in that case your examination is also started from the inspection. So be careful, be attentively, at first listen what question you will ask. So as a whole, now I am going to show you the detailed full obstetric examination. At first inspection, and of course you must be at the stand at the right side of the patient. You must maintain the privacy and exposure of the patient, and start to describe the inspection. On inspection, how you describe the obstetric abdomen. On inspection you say the তার আগে একটা কথা বলে নিচ্ছি আপু, this abdomen কে আপনারা we can consider it as a 28 weeks of pregnancy, and সেভাবে আমরা এটাকে ডিসক্রাইব করতেছি। আপনি যে গেস্টেশনাল এজি পাম সেটা হচ্ছে আপনি ওভাবেই ডিসক্রাইব করবেন। অন ইন্সপেকশন, এখানে আরেকটা জিনিস আমি বলে নিতে চাচ্ছি যে ইন্সপেকশনের ক্ষেত্রে আমরা কিছু ওয়ার্ড ইউজ করি, যে অ্যাবডোমেন ইজ unduly enlarged, hugely enlarged, excessively enlarged. এই ধরনের টার্ম আসলে কিছু স্পেসিফিক কথা আছে, যেমন ইন অবসে ক্ষেত্রে প্রেগনেন্সি, সিম্পল প্রেগনেন্সির ক্ষেত্রে আমরা বলবো অ্যাবডোমেন ইজ enlarged enough. But if it is polyhydramnios, if it is multiple pregnancy, in that case you can use the word unduly enlarged. If it is ascites, you can express it as the abdomen is hugely enlarged. Polyhydramnios, hugely enlarged, unduly enlarged. Suppose hydrocephalus baby, you can explain it as a unduly enlarged. Unduly and excessive enlarged একই কথা, বাট একটা সিম্পল আপনার পলি মনে হচ্ছে না, ম্যাক্রোসোমিক মনে হচ্ছে না, তাহলে সিম্পলি সে দ্যাট abdomen is enlarged. So on inspection, abdomen is enlarged with the visible stria gravidarum, and the umbilicus is inverted, everted, whatever it is, and the overall skin condition is good. But if it is any evidence of the polyhydramnios, you must mention that the overall skin is tense, shiny, there is large stria, and the abdomen is hugely distended, hugely enlarged. And in case of the macrosomic or যেটাই হোক, আপনার ইন্সপেকশনের পয়েন্টগুলো জাস্ট এভাবেই কভার করবে। দেন then palpation. The obstetric palpation, the first part of the obstetric palpation is palpation of the symphysiofundal height. Be careful. এই কারণেও কিন্তু অনেক এক্সামিনির পরীক্ষা সবকিছু পারা সত্ত্বেও ফেল হয়েছে। কোশ্চেন ছিল পালপেট দ্য শো মি দ্য অবস্টেট্রিক গ্রিপ, সেখানে আপনি অবস্টেট্রিক গ্রিপ থেকে শুরু করলেন, আর পালপেট দ্য অ্যাবডোমেন সেক্ষেত্রে কিন্তু ইয়োর ফার্স্ট পার্ট ইজ সিমফাইসিওফান্ডাল হাইট, সেখানে আগেই যদি অবস্টেট্রিক গ্রিপ দিয়ে শুরু করেন তাহলে কিন্তু আপনার একটা স্টেপ স্কিপ হয়ে গেল। সো ইউ শুড স্টার্ট উইথ দ্য সিমফাইসিওফান্ডাল height and be remember that the first part of the obstetric abdomen palpation is the symphysiofundal height palpation. So this is the drama. The palpation of the measurement of the symphysiofundal height is the drama. Sometimes you will asked only to show the symphysiofundal height. So that is depends. তো এখানে অনেক রকমের সমস্যা হয়, দেখা যায় এই মেজারিং টেপটা ঠিক মতো খুঁজে পাওয়া যায় না। তো আপনারা যারা এক্সামিনার আমি তাদেরকে তো বলবো অলরেডি ইউ হ্যাভ টু অ্যারেঞ্জ এ ইনস্ট্রুমেন্টাল বক্স এবং সেখানে আপনার প্রয়োজনীয় সব কিছু গুছিয়ে ফেলেন। তো এই মেজারিং টেপটা আপনার হচ্ছে ইউটিলাইজেশন করা, ওখানে this is the art of the movement. By observation of the movement of your hand, the examiner will make a clear conception about you, how much practice you have done. So এখানে আমি this is the tips যে during the symphysiofundal examination it will sometimes it becomes very clumsy, this end comes first and তারপর এটা চলে আসে, ঠিকমতো খুঁজে পাওয়া যায় না, এভাবে উপরে নিচে কোনটা হবে সেটা বুঝতে পারা যায় না। So you are wearing the apron, so your task is just the important end, that is this end, not the opposite end, not this end, where this end you will use this end. So the this end will be outside the apron. That will be very helpful because at that time your time is very short, কয়েক সেকেন্ড অথবা উইদিন এ মোমেন্ট আপনাকে এটা দেখাতে হবে। আসসালামু আলাইকুম। Now I will show the obstetric examination and this is compulsory in all of your obs case. Obstetric examination should be started with the inspection. Here the most important thing is that during examination you have to concentrate what question you have been asked. If it is show me the obstetric examination, in that case your examination will be start from the inspection. If say the show me the obstetric grip, in that case your examination will be start from the fundal grip. If you are asked to show the only symphysiofundal height, then your examination is only see the symphysiofundal height. If your question is examine the abdomen in your obs case, in that case your examination is also started from the inspection. So be careful, be attentively, at first listen what question you will ask. So as a whole, now I am going to show you the detailed full obstetric examination. At first inspection, and of course you must be at the stand at the right side of the patient. You must maintain the privacy and exposure of the patient and start to describe the inspection. On inspection, how you describe the obstetric abdomen. On inspection you say the তার আগে একটা কথা বলে নিচ্ছি আপু, this abdomen কে আপনারা we can consider it as a 28 weeks of pregnancy and সেভাবে আমরা এটাকে ডিসক্রাইব করতেছি। আপনি যে জেস্টেশনাল এজি পান সেটা হচ্ছে আপনি ওভাবেই ডিসক্রাইব করবেন। অন ইন্সপেকশন এখানে আরেকটা জিনিস আমি বলে নিতে চাচ্ছি যে ইন্সপেকশনের ক্ষেত্রে আমরা কিছু ওয়ার্ড ইউজ করি যে অ্যাবডোমেন ইজ unduly enlarged, hugely enlarged, excessively enlarged. এই ধরনের টার্ম আসলে কিছু স্পেসিফিক কথা আছে, যেমন ইন অবসে ক্ষেত্রে প্রেগনেন্সি সিম্পল প্রেগনেন্সির ক্ষেত্রে আমরা বলবো অ্যাবডোমেন ইজ এনলার্জড এনাফ, But if it is polyhydramnios, if it is multiple pregnancy, in that case you can use the word unduly enlarged. If it is ascites, you can express it as the abdomen is hugely enlarged. Polyhydramnios, hugely enlarged, unduly enlarged. Suppose hydrocephalus baby, you can explain it as a unduly enlarged. Unduly and excessive enlarged একই কথা, but একটা simple আপনার poly মনে হচ্ছে না, macrosomic মনে হচ্ছে না, তাহলে simply said that abdomen is enlarged. So on inspection, abdomen is enlarged, with the visible stria gravidera, and the umbilicus is everted, whatever it is, and the overall skin condition is good. But if it is any evidence of the polyhydramnios, you must mention that the overall skin is dense, shiny, there is large stria, and the abdomen is hugely distended, hugely enlarged. And in case of the macrosomic or যেটাই হোক, আপনার ইন্সপেকশনের পয়েন্টগুলো জাস্ট এভাবেই কভার করবে। দেন then palpation. The obstetric palpation, the first part of the obstetric palpation is palpation of the symphysiofundal height. Be careful. এই কারণেও কিন্তু অনেক এক্সামিনের পরীক্ষা সবকিছু পারা সত্ত্বেও ফেল হয়েছে। কোশ্চেন ছিল palpate the show me the obstetric grip, সেখানে আপনি obstetric grip থেকে শুরু করলেন, আর palpate the abdomen, সেক্ষেত্রে কিন্তু your first part is symphysiofundal height, সেখানে আগেই যদি obstetric grip দিয়ে শুরু করেন তাহলে কিন্তু আপনার একটা স্টেপ স্কিপ হয়ে গেল। So you should start with the symphysiofundal height, and we remember that the first part of the obstetric abdomen palpation is the symphysiofundal height palpation. So this is the drama. The palpation of the measurement of the symphysiofundal height is the drama. Sometimes you will asked only to show the symphysiofundal height. So that is depends. তো এখানে অনেক রকমের সমস্যা হয়, দেখা যায় এই মেজারিং টেপটা ঠিক মতো খুঁজে পাওয়া যায় না। তো আপনারা যারা এক্সামিনার, আমি তাদেরকে তো বলবো অলরেডি ইউ হ্যাভ টু অ্যারেঞ্জ এ ইনস্ট্রুমেন্টাল বক্স, এবং সেখানে আপনার প্রয়োজনীয় সব কিছু গুছিয়ে ফেলেন। তো এই মেজারিং টেপটা আপনার হচ্ছে ইউটিলাইজেশন করা, ওখানে this is the art of the movement. By observation of the movement of your hand, the examiner will make a clear conception about you, how much practice you have done. So এখানে আমি this is the tips যে during the symphysiofundal examination it will sometimes it becomes very clumsy. This end comes first and তারপর এটা চলে আসে, ঠিকমতো খুঁজে পাওয়া যায় না, এভাবে উপরে নিচে কোনটা হবে সেটা বুঝতে পারা যায় না। So you are wearing the apron, so your task is just the important end, that is this end, not the opposite end, not this end, where this end you will use this end. So the this end will be outside the apron. That will be very helpful, because at that time your time is very short, কয়েক সেকেন্ড অথবা উইদিন এ মোমেন্ট আপনাকে এটা দেখাতে হবে। Now I will show the parvaginal examination of the carcinoma of the cervix. If your case is CS cervix, your total clinical findings will be on the depending on the stage of the disease, but just as a pro forma, just I am presenting a case of the cervical cancer parvaginal examination. As usual, at first inspection, you see this. Okay, now I will show the parvaginal examination of the CA cervix. At first inspection, what will you say during the inspection? Inspection, as usual, vulvoperineum is apparently healthy or normal. The important comment is whether there is active PV bleeding is present or not. You can say that there is no active PV bleeding and no foul smelling discharge is coming through the introitus. Now, parspeculum examination. In case of the HCU cervix, you have to introduce the parspeculum, and this is of course the cascus speculum, but very gentle, very careful, and after taking the consent that there is every chance of the active bleeding, or sometimes the bleeding is so huge in amount that examination procedure may be stopped. As usual, just apperting the labia majora with the thumb and index finger, just like this, introduction of the cascus speculum, and you can fix it. Your examiner can want to see the cervix. Then you inspect the cervix, that a growth is visible either in the anterior lip or in the posterior lip. Suppose okay, I can do it. So you can describe the growth just like this. The growth is visible on the involving the anterior or posterior lip, or both of the lip of the cervix, or maybe the both lip of the cervix is flushed out, or only anterior, only posterior lip, whatever you say. Then during after description of the growth, then you can say that of course it is with the right hand. During the withdrawal of the speculum, there is the vaginal wall is healthy and there is no growth. I am waiting for Azan. After completion of Azan, I will start again. then I will describe the bimanual examination. As usual, bimanual examination you can describe like this, that at first cervix, the ulcerative cervix is either broad, hypertrophied, and ulcerative growth is felt into the anterior, posterior, in both lip of the cervix. Cervix is flushed out, and the growth is hard, fixed, tender, and restricted. Hard, fixed, tender, and restricted. But be careful in ulcerative growth. You should not mention that it is friable. All the criteria of the cervical growth, cancer growth, is not applicable in all type of the growth. So if it is cauliflower, if it is ulcerative, you can say it is fixed, it is tender, it is hard. But in case of friable growth, in that case, cauliflower growth, in that case you can say it is friable. This is about the cervical growth. Then all the fornix are free. No growth is felt through posterior fornix, and there is no added adnexal mass is felt. And here one of the important thing in here, if the parametrium is involved, then you can say that it is fixed. If parametrium is not involved, you should mention that the growth is mobile. So be careful what will you say. Your demonstration will be just according to your clinical examination. Then after doing the bimanual examination, now I will do the rectovaginal examination. And rectovaginal examination ta jodi apni dekhate chan, she khetre just the rectovaginal examination is cardinal examination for cervical cancer, for malignancy, endometrial cancer. So how you will do the rectovaginal examination? Just when I will do the bimanual examination, suppose I am doing the bimanual examination, during for rectovaginal examination, when I am doing the bimanual examination, this finger should be slightly withdrawn. This finger should be both the finger is slightly withdrawn, and index finger, just both the finger should be placed in the introitus. Already I am in, because I am doing the bimanual examination. Then index finger will be inside, but withdrawal of the middle finger. In digital rectal examination, usually in digital rectal examination, usually we do the digital, usually we do it with the index finger. But here, in case of the rectovaginal examination, you have to use both index and this finger. So this index finger will be within the vagina. In that case, this thick middle finger will enter into the rectum, just like this. Here and here, just like this. ইন্ডেক্স ফিঙ্গার ভ্যাজাইনা এবং এখানে দেখার বিষয় হচ্ছে বাইম্যানুয়াল এক্সামিনেশন করার সময় আপনি টোটাল হ্যান্ড উইথড্র করবেন না, ইন্ডেক্স ফিঙ্গার ভিতরে থাকবে, অনলি দিস ফিঙ্গার উইল বি উইথড্রন অ্যান্ড ইট ইজ অ্যান্ড বাই দিস টাইম ইউ ask your assistant or sister to lubricate this finger. Then you can introduce to the rectum, and now just do a gliding movement. Just do a gliding movement. At that time, your left hand must be placed over there and and compress it. When compressed it, and during this time, vaginally you feel the consistency of the uterosacral ligament, and the comment should be like that. There is no thickening of the parametrium. There is no parametrial thickening. Rectal mucosa free, and no thickening of the uterosacral ligament. Finally, you can say your diagnosis. CA cervix এর diagnosis বলাটাও একটা আর্টিস্টিক ওয়েতে বলতে হয় যে CA cervix এর diagnosisটা আপনি হচ্ছে if you say very shortcut diagnosis, then the further question will arise the explain it. So as a one time you can say, as the growth is confined to the cervix. And one thing I have already probably I missed in the demonstration, when you describe the cervical growth, it occupies the lip of the cervix, you should mention the size. It seems to be 3 into 3 centimeter, 2 into 2 centimeter in diameter, but obviously, of course, during the bimanual examination, not in the paraspeculum examination, you should not mention the size during paraspeculum examination. So finally, you will say that as the growth is confined to the cervix and no other growth is felt through the posterior fornix, and vaginal wall is also free, and this is the CA cervix stage 1B1, 1B2, whatever you say. So this is all about the cervical cancer examination. So আপুরা ফাইনালি বলেন, ক্লিনিক্যাল এক্সামিনেশনের ক্লাসটা হচ্ছে আপনাদের হচ্ছে জানি না এক্সামিনি যারা আছেন তাদের কোনো উপকার হয়েছে কিনা, আর যারা নন এক্সামিনি যাদের এবার হচ্ছে রিটেন হয়নি, কোনো ব্যাপার না, সবাই আজ এখন থেকে আবার শুরু করেন। and these clinical examinations will be a milestone for your preparation, কারণ এক্সামিনেশনগুলো দেখানো আসলে আমি নাও আই এম ফিলিং আমার অনেক কষ্ট হয়েছে, আমি কিন্তু এক্সামিনেশনগুলো আর দেখাতে পারবো না। সো হচ্ছে গতকালকে আমি হেডফোন ছাড়া রিসেন্ট আপডেটের ক্লাসে চিৎকার করে আমার হচ্ছে গলা প্রায় হচ্ছে অবস্থা খারাপ, এবং আজকে তো আরও গলা বসে গেছে। সো এই কষ্ট কিন্তু বারবার করা যাবে না। সো সবার কাছে রিকোয়েস্ট, লাইভ ইনস্ট্যান্ট ক্লাসটা সবাই একটু অ্যাটেন্ড করে অন্তত জাস্ট ওয়ান্স জাস্ট সিঙ্গল শট হলেও এক্সামিনেশনগুলো একবার দেখে নেন। দ্যাট উইল বি ভেরি হেল্পফুল ফর দ্য প্রিপারেশন অফ ইউর দ্য ক্লিনিক্যাল কেস। তো হচ্ছে সবার জন্য অনেক বেশি শুভকামনা, অ্যান্ড থ্যাংক ইউ সো মাচ ফর স্টেইং উইথ মি ফর এ সো লং টাইম। আর হচ্ছে সবার জন্য দোয়া করি সবাই পাশ করে যান। আপনারা পাশ করলে তো আমারই লাভ, কারণ হচ্ছে আমাকে অনেক বেশি আমি কিন্তু বলে দিচ্ছি, আমি কিন্তু হচ্ছে মিষ্টি খাবো না। যারা পাশ করবেন মিষ্টি খাবো না, কারণ এত মিষ্টি খেয়ে দেখা যাবে আমার আবার ওয়েট গেইন হয়ে যাবে। সো সবার জন্য শুধু দোয়া করে দিব, সবাই ভালোভাবে পরীক্ষা দেন, পাশ করেন। আর যারা হচ্ছে এখন মন খারাপ করে বাসায় থাকার সময় না, জাস্ট একটু টাইম স্পেন্ড করেন উইথ দ্য ফ্যামিলি, তারপর আবার নতুন করে শুরু করেন। আপনি একটা প্রসিডিউরের মাঝখানে আছেন, এটা টুডে অর টুমোরো অবশ্যই শেষ হবে। সো থ্যাংক ইউ সো মাচ ফর স্টেইং উইথ মি, অ্যান্ড বেস্ট অফ লাক ফর এভরিওয়ান।